welcome to Senior Focus. Happy that you're able to join us today. I have with me today as a guest Dr. Carol Barrette. Did I say that correctly? Dr. Barrette? And Don Osterguy.
Hi, Nick.
Dr. Barrette, how are you today?
I'm good, thank you.
Is it hot enough for you out there today? In the medical profession, I think that you'd be the first one to tell people to make sure they adequately hydrate themselves on days like today.
That is correct.
So we're going to talk about orthopedic surgery today. You're an orthopedic surgeon, is that correct?
Yes, I'm a very specialized orthopedic surgeon. I am a foot and ankle orthopedist, so I deal mainly with lower extremity problems. Unless I'm on call and you break something,
Okay.
we take care of everything. But other than that, we take care of very complex lower extremity problems from below the knee down.
And how long have you been a surgeon?
I've been a surgeon for about 25 years. I've been in Worcester for about 20 years. And before that, I was down at Yale for my 5 years of residency, and then I came from Chicago.
Is there anything in particular that drew your interest in surgery?
It's actually interesting. The only reason I did an orthopedic rotation when I was a medical student was because that's what my father did. But he never talked about what he did.
Okay.
So I took orthopedics just to see what my dad did for a living. I had no idea that I would actually fall in love with it. And the biggest trick was my father, who was an old-time orthopedic surgeon, was telling him that I, a woman, was going to go into orthopedic surgery when he was sort of interested in me being a nurse. But as things turned out, he was my biggest supporter, and down the road we ended up discussing cases, and he would ask me, all right, well, how do you do this, and how do you do that, and what's the latest on this, and it's actually been great.
I was in the 6th grade and I broke my femur. I was riding my bike and my bike slipped on sand. It's a harmless little fall, and I broke my femur. I presume that there's been tremendous advances since that time.
Oh, sure. When I started treating broken femur fractures in 6-year-olds in 1992, we had to hang them in traction and adjust x-rays every 2 or 3 days until the fractures got sticky enough to get them out. And now they have flexible rods that we put in, and people can get up and walk. So it's very rare to have to do that, what you may have had to go through.
Well, I can remember that I think I was at City Hospital, and I was there for months. I was in traction for months. And what I can recall is they had bags of sand that would, like, I don't know, they were like pulling on my foot, and there were these 2 little kids, I don't know, what were they, 5, 6 years old, and they'd get out of their beds and they'd swing the bags. And I can remember yelling, "Nurse, nurse!" What are your clinical interests?
I particularly like lower extremity deformity. So although I take care of everything in the lower extremity, the more deformed the people are, the more that they have things like cerebral palsy, or they've had a stroke, or they have some type of neuromuscular problem in which there's a muscle imbalance and they end up with tremendous deformities. I like straightening those out. And I like the people with, I'm sorry that I have to see them, but, but I enjoy them. People that come in with the very bad diabetic deformities, and where all the bones have broken in, the foot is remodeled, and they have tremendous bony prominences, and trying to figure out how exactly to get this person back on their feet with the least thing possible that's going to interfere with them. People that come in that have rheumatoid arthritis, I particularly like. The worse the deformity, the happier I am, and actually the happier the patients are when all is said and done. So I like things like that, and the worse the better, really.
That's kind of scary because you're saying that deformity, you're thinking the worse the better in a sense, but is it treatable, those deformities, honestly? Because you think that this is going to be something you'd have to live with forever, and yet you're saying there might be hope or cases that you could function again, walk again, live a, we'll say, fulfilling life, being able to do what you'd like to do.
Well, mostly these are people who are walking about. They just have a lot of discomfort while they're walking about, or the foot is so deformed they can't fit a shoe on it anymore, or the leg is rotated out to the side. It's very difficult to walk. So these are not people that are in extremis. They're people having difficulty doing their activities of daily life. And so by doing my particular thing of straightening out the foot, or taking care of the painful joint, whatever it is, shrinking the deformity so they can wear an off-the-counter shoe, things like that, you can make their life much more livable. You may not necessarily be able to get rid of every iota of pain, but you can make their particular problem much better. And those people are very grateful. They are very happy for anything that you can do for them, in contradistinction to the average athlete who not only wants you to do the surgery, but the day after surgery they want to play football. And there's no room for error. So these people I'm talking about, they're very grateful. They're very difficult, but the rewards are great, both for them and obviously
And
I think for
yourself.
me, because I enjoy taking care of them. So I'm willing to look at any deformity, no matter how bad. Now, there are some circumstances in which maybe people have too many medical problems, or they don't have enough blood supply, or their social circumstances are such they won't be able to be non-weight bearing, or something will happen where the surgery will fail. Well, those people would not be able to have surgery. Maybe you can't do the one that would be the board answer, but you'd be able to find some way, somehow, to help them. And again, so it involves a lot of different thinking out of the box to try and figure out what can you do to get this patient functional enough to do what they need to do, which is different for someone who's 89 versus someone who's a 20-year-old athlete. So
that's what I wanted to ask you. We all know that there is a crushing. Oh my gosh, that's okay. There's a crushing load of seniors right now. I think that what was it? Social Security Administration said something like 10,000 people a day turn 65, which is a number that is, I don't know, it's difficult for me to fathom it, but 10,000 a day turn 65. In your practice, from when you first began to today, have you noticed a particular demographic where your patients are getting older?
I would anticipate if I was in any other part of the country besides Worcester, that might be true. But Worcester has historically had a very large number of older people. So possibly if you're from La Jolla, California, you may see something like that. But in Worcester, there's always been a particularly large number of older patients. And because there's been such a large number of older patients in Worcester to begin with, I think that's why people like myself, we have a lot more experience with older people, because we've had it since the moment we finished our residency programs. We have people that are over the age of 65, 75, 85, 95. I mean, some of the things that we've done in people that are in their 90s, because they are very healthy walkers, talkers. In fact, I have 95-year-old patients that are healthier than some of these 30-year-olds that are coming up now. So the average person who's 65, 75, 85 right now, they're healthier than this crop of 30-year-olds that's coming up.
A lot of, we'll say, the intervention, people asking for your assistance, seems to be as a result of other ailments that they're suffering from that have caused some kind of a deformity or complication in we'll say, in your language, their lower extremities. Is there a particular team approach? Like, what's your role? How does it happen?
Well, some of the problems really aren't going to need a team approach.
Okay.
The biggest one that needs a team approach is going to be diabetes, because so many things go wrong. The average diabetic is living so long these days, and if you don't control your sugars well, or if you get the diabetes when you're younger and you're just not controlling your sugars, you're not really thinking about it, it really builds up on you. It's sort of like people that have high blood pressure, the silent killer, and they don't really take care of it, and the heart wall gets thicker, 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 and there you are. You have a very thick-walled heart, and you're going to get a heart attack. And diabetes is the same way. It's sort of a silent thing. You're young, you don't want to watch your diet, you don't want to be sticking yourself, and the sugar builds up, and then it settles into the nerves, and you end up with numbness, and then it affects your eyes and your kidneys and your heart and the blood vessels. And then if you do something foolish like smoke, in addition to being a diabetic, that just makes everything from smoking and diabetes magnified, especially if you're a female and you have diabetes and smoke. So there are some things that really affect you in every single organ system, and diabetes would be one of those. Another thing that can happen is people that have strokes. I mean, there's different reasons for having strokes, so the neurologist is very important for those people. Some people have neuromuscular conditions, and so having physiatrists and physical therapy on board too. And the people who have cerebral palsy, they're at a particular disadvantage. The people who have the spinal cord problems and the cerebral palsy, they're taken care of by incredibly highly skilled, specialty trained pediatric orthopedists. And the moment they turn 18, they're dumped into the pool of orthopedic surgeons that don't take care of any of those things. I mean, for people like myself, where I did have a very intense pediatric rotation, and I have an interest in that sort of thing, and I wrote papers on cerebral palsy and hemiplegia. It's a little different. I mean, I can take care of these people, but for the people with hemiplegia and cerebral palsy, they don't have that specialty trained orthopedic surgeon anymore because they won't see them after the age of 18.
Now,
and then they have to find care. It's very difficult for them.
Everyone's heard the words cerebral palsy. What is that?
The definition of cerebral palsy, I'll probably get this a little bit wrong, but it'll be an insult that happens to the brain, and you're born with that. So because of this stroke or other abnormality, whether it's the cord around the neck or whatever causes your brain abnormality while you're in the uterus and you come out, leads to motor sensory abnormalities. It's like having a stroke when you're our age. But when you're young, that really, an infant, that has yet to grow into a full-fledged adult, then there's a whole scope of problems that occurs with that.
So it sounds like you become involved not only like strictly with skeletal disorders, but we'll say with musculoskeletal disorders. Is that correct?
Yes, when you're a foot and ankle orthopedic surgeon, you deal with all of those things. The average orthopedic surgeon will not deal with this kind of thing. When you're foot and ankle, because so many problems happen, the people with cerebral palsy, they get tight tendons, they're walking on their tiptoes, the feet turn out to the side, they get tremendous deformities. So again, you have to deal with those type of people, and it's going to happen more in the lower extremities than elsewhere. The hand too, also the hand guys have to deal with things like that.
Now, you mentioned that because of the location that you're in Worcester, there are a lot of older patients. Is someone ever too old for surgery?
No, not in this day and age. There's people that when they're 30 years old, they're not candidates for surgery because they are too old. They're not going to be compliant. They're mentally not with the program. They're heavy smokers. They don't have any teeth. Some of these people, they're not as healthy as my average 80-year-old. So what it comes down to is, does the patient have a realistic goal for surgery and a problem that can be treated that they can recover from? And this is where the people who are older get into trouble. They have a lot of other medical problems, not always. I mean, my great aunt-in-law is almost 90, and she looks 50. She picks up my son. She runs around. She does everything. She is not your average 90-year-old. She's healthier than a 30-year-old. She could have any surgery that's done. So you have to evaluate every patient. Do they have good skin? Do they have good blood supply? Are they mentally with the program? Do they have a good support system that they can get through the surgery? Are they going to be able to recover appropriately? And if they're going to be able to heal the wound, recover from the surgery, you have a very clear-cut goal of what you're doing to improve their life, yeah, they can have surgery.
So seniors watching the program today, or caregivers of seniors, need to realize that age is simply one of the many factors that you look at to determine whether surgery is indicated for a particular patient or not.
That's correct. There's old and then there's old. And there is no real age group at which you become old. It's a combination of how healthy are you? And so even today in my office I saw a lady that's almost 80, and she has a horrible deformity. And I'm like, look, if you ever can't do the things you want to do, if your life is so miserable because of pain that you can't do the things you want to do, then all right, I'll go down this road with you, because what's the worst that could happen? You might lose your leg, I'll give you a prosthetic, you'll run around, you'll be better than you were sitting at home doing nothing. So there are many times that I will go down the road on someone who's 80 with them to try and help them improve their function so they can do the things that make their life worth living. If they're just sitting on a couch and they're in such pain by whatever's going on in their foot and ankle, what life is that? If they have the ability to recover from the surgery, the blood flow, the good skin, they don't smoke, then yes, I'm going to go down that path with them because I can improve them.
Oftentimes you hear of the term, or at least I heard of the term today, geriatric orthopedic surgery. Is there such a thing?
I haven't really heard that term, but my suspicion would be your average osteoporotic fracture, the proximal humerus fractures, the wrist fractures, the hip fractures, the things that
surgery
happen
for an
when
aging population.
Right, the things that happen when you fall down, or sometimes the hip breaks and then you fall. Those kind of things would be more of a geriatric sort of thing. And the bone, it's an organ system just like the heart. So if you break your hip, for instance, it's a big deal. It's like having a heart attack or a stroke or a GI bleed. It's a big deal. It's a stressful situation. It takes an elderly person who's probably fine-tuned on a little tightrope between possibly living independently, maybe in an assisted living, and now they've broken their hip. And generally, I mean, for the most part, I can kind of get people back to where they were, but I'm not going to make them better. You already walk with a walker. Well, you know, you may end up not being able to go home and be independent. So these fractures are a huge deal when they happen. You want to delay them as much as possible, in every way try to prevent them, so that if you are in your 80s or 90s and you're living at home independently, you don't want one of these fractures, because it could take you from living at home and being independent to being in a nursing home, and there's a pretty, you know, there can be a significant decline after that transition happens. So,
well, we're going to have to head to a break right now, but when we come back, I would like to talk to you about, is there any specialized training for an adult or a senior patient that needs orthopedic surgery?
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Charter TV3 and UMass Memorial Healthcare have teamed up to bring you the latest news and trends in healthcare. Health Watch, presented by UMass Memorial Healthcare, brings you the healthcare topics that are important to you. From stroke prevention to allergies, skincare to sports injury prevention, and nutrition to pregnancy, Health Watch and UMass Memorial Healthcare informs you on the issues that affect you on a daily basis. Health Watch on Charter TV3. For extended interviews with UMass Memorial Healthcare experts, log on to our website.
I know everybody agrees with me that it's wonderful to see construction cranes in Worcester, despite the economy. We've got the mall going down, we've got buildings going up. Here in the Canal District, we've got streetscape happening, the colleges are all building. Things are happening in Worcester. We hope to be talking about all the issues that affect Worcester. There's a lot of development going on despite the economy, a lot of interesting politics, always our share of scandal and whatnot, and we hope to have a lively repartee.
Charter Business helps businesses achieve everyday victories. Want to be victorious today? Call 877-BIZ-BUNDLE and switch to Charter Business Internet and phone for just $99 a month. You'll enjoy internet 6 times faster than standard DSL, plus unlimited long distance. Getting a business bundle for just $99 a month makes for an easy decision. But hurry, because this offer won't last. So call 877-BIZ-BUNDLE today. To the victor go the spoils!
Tired of weather reports that don't focus on Central Mass? Introducing Worcester Weather, the only video weather report for Worcester. Worcester Weather is easily accessible 24/7 by visiting chartertv3.com. It is updated throughout the day to give you the best video forecast possible. Worcester Weather also airs at 5 p.m. during the Jordan Levy Show and every Worcester News Tonight telecast. Worcester Weather gives you the local forecast you have always wanted. Worcester Weather on Charter TV3 and chartertv3.com. Brought to you by Berterra Nissan of Auburn.
I'm Caitlin Tivnan from Worcester News Tonight. Thank you for choosing Charter.
Welcome back to the Senior Focus. I'm your host, Attorney Nick Koltzis, and I'm here today with Dr. Carol Barrette and Donna Osgay. Dr. Barrette's from Premier Foot and Ankle Center, is that right?
that's correct.
Okay. Let me ask you, I was going to ask you a little bit about special training, But I think that first I want to say, have there been any advances that for orthopedic surgery that make it easier on a senior patient, on an elderly patient?
Well, there's been a lot of orthopedic advances, I think, that one of our big focuses, especially with trauma, is getting the patients up moving quickly. The lungs don't like it when you lie down in bed. You get a pneumonia. You can have more mental compromise, skin sores, big time problem if we don't get people up and moving, like after hip fractures, things like that. And hip fractures in particular, we're very good at that now. We can fix a hip fracture, and the moment we fix it, you can put weight on it. So that's a very useful thing. We will fix hip fractures as fast as we can so people don't lie down endlessly in pain, unable to move, and get medical problems such as pneumonias, blood clots, bed sores.
Geez, I can remember the idea that if a senior had a hip fracture, it was the most terrible. It was curtains, exactly.
It was.
Is that necessarily still the case today?
If you don't fix them, if you don't fix a hip fracture, essentially you're looking at 100% mortality within the first 2 weeks. So even in patients they do not know where they are totally demented, we still fix these for humanitarian reasons.
Right,
It's terribly painful. And in patients who are with the program, so to speak, definitely you want to fix them, even if your risk of surgery is huge. If the cardiologist says, oh, you have a 90% chance of not making it, okay, fine. Well, how often do people really die on the table? Not 90% of the time, I can tell you that. So even that 10% chance that you don't want to be lying there with a hip fracture is extremely painful. They have to medicate you. You're totally out on medication, and you get a pneumonia. It's an uncomfortable way to go. So situations like that, we fix people right away. There's a lot of ways to fix shoulder fractures so people can move about. We try to fix tibia fractures as a prime example. A tibia fracture in the past, trying to treat people in a cast and hauling the cast around, being on crutches and a walker for the average senior is very difficult. If I fix a tibia fracture with a rod and cross screws, I put them in a removable cast and I let them weight bear. So femur fractures, where the femur itself shatters, we put rods in, and depending on how stable the fracture is, we can let them put weight on it right away so that they can get up and be more mobile. So yes, as hardware has been fine-tuned, and as we've become much more adept at doing these types of surgeries, we're able to do a lot of surgeries in which patients can get up right away and move around.
Now, I know it was a long time ago. The one thing that really stands out and stays with me is the pain that I had when they took an x-ray of my leg. Is it still the type of thing where if you have a break, the diagnostic test is so painful?
Well, I suspect if you treated your femur fracture today, like they did before, you're still going to have pain because they still have to take the x-ray plate and put it under your leg and put the portable on top and what have you. So they have to move you around a little bit, and just like the guy swinging the sandbags at the bottom of your traction device, that probably wasn't comfortable for you either.
No, that wasn't fun at all.
So anyone moving your leg until the bone became sticky with new bone, until the bone superglue started to heal, would have been very uncomfortable for you. And a part of it, being a kid, would be just the fear of it. If it hurt the very first time, kids heal very quickly. So the first time might have been painful, but then it would have been more of a fear of the event happening, even though it may not have been so uncomfortable afterwards. But for the most part, putting hardware down the fractures makes a big difference. We're still a little bit limited in kids because they have growth plates. So we have some ways, the pediatric orthopedists again have some ways of snaking little flexible rods in and avoiding the growth plates to try and stabilize these fractures so people don't have to go through with what you did.
What's a growth plate?
The growth plate is the ends of the bones around the joints that grow. And they're weak points in the bone structure, so if you have an injury, it can often occur through them. A growth plate injury, you may have heard of that. So the bones grow through the growth plates. The muscles kind of get tugged along behind as you're growing. And then when you're somewhere between 12 and 21, depending on the particular growth plate, the growth plates are in all joints and all bones, so they do close at varying times. But for the most part, at least around the ankle, they start closing around the age of 13 in a female and 15 in a male. There are outliers. So around the ankle area where I am most of the time, the growth plates close by the time you're 16, 17.
Now, we talked a little bit about the growth plates in a younger patient. What about an older patient? Is there specialized education or procedures that are employed by orthopedic surgeons? Or?
Well, we are all extremely well trained in taking care of the fractures that occur that are common, the wrist
Regardless of the
fractures,
age.
although the hand people
Right.
tend to do those now. The shoulder fractures, although again, there's shoulder specialists too. The hip fractures we all do. As far as the things that I particularly do, when patients break their ankles, it's different from the break in a young person. Bone is like a crystal, and you just hit it, it'll break in two. And that's what the average young person's ankle fracture is. It's a simple, clean fracture. There'll be two pieces. It's not, for the most part, not always, it's not going to be a smash thing. But when the average person in their 70s and 80s breaks their ankle, it's in many pieces. And the
Why is that?
The bones are very brittle, and they just go, and they break in multiple places. So the problem comes in is that the soft tissue envelope, the skin and the soft tissues are often bruised and traumatized, and the skin in an older person is very thin, especially if they've been on steroids. They often have a lot of swelling because they have varicosity. So it becomes a very difficult thing. You want to make your incisions in the exact spot you need them. You want to make them as small as possible. You have to baby the wounds along. And you have to use more hardware than you otherwise would. In a young person, I can sometimes use 1 or 2 screws to fix a fibular fracture. The fibula is a little bone on the outside of the ankle. But in an older person, I have to use a plate, and I have to use many screws, and I have to secure the screws right to the tibia bone. So you need more hardware to stabilize these fractures that are where the bone is so weak and there's not very much bone. You have to go out of your way. So a lot of that is experience. If someone comes into our hospital and they have a really shattered fracture, it's the kind of thing where it's a good thing when I'm called to evaluate the patient and figure out what to do to stop problems. I see sometimes hardware has been put in and the bones are very osteoporotic. The hardware stays right where it's put, and the bones just melt right off the hardware. You need more hardware, more fixation. You have to be more careful. You cannot be cavalier. The wounds, you have to foul them sometimes twice a week to make sure that there's no problems. There's all sorts of little tricks that you have to use to make sure that the wounds heal, the swelling goes down, they don't get a blood clot, the bones heal, and that they get back to their activities.
So you're looking at a big picture instead of, say, with a child, and you don't know the time frame that it might heal, and it's this is what you
kids
put
heal
in.
Easy.
With adult, it's, well, we'll say an older adult. I know when my mom broke her foot, we had gone to Dr. Barrette, and I have to tell you first that she loved her because she was very compassionate and rubbed my mother's foot. My mother took that as one of the highest things in the world, I'll tell you. But I remember going back time and time again, and it took a long time to heal that. She didn't need surgery, luckily, thank God. But you kept making the reference that it was almost like, not a cloud, but soft. You could see it healing.
Yep.
It just took a very long time to heal.
Took a while to heal and stabilize, right?
Yeah.
So you have to be very, very patient. And you have to really invest the patience in what you're doing too. You can't just run in the room and look at it and run out. I mean, you have to sit there and you have to talk to the patients and say, okay, well, this is what we're looking for, and here's your x-rays, and I'll copy the x-rays off, as I probably did with your mother, and show, well, look, we're improving here, we have a little work to do here, and get them invested in staying off of the foot. And as soon as you think that they can put weight on it, letting them put a little weight on it, and trying to get them to do what you want. It's half of what I do, I
It's
think,
half
is
the
being
battle.
a psychiatrist.
Half the
It
battle.
really is.
Even a caregiver, half the battle is getting them to stay in that boot long enough, because you didn't put a hard cast on her. But the fact that she had to have it, and then we went back probably 6 weeks later and it wasn't quite healed, she needed 2 more weeks. That was tough.
Right.
And I think it's the patience factor of giving it time to heal properly, and sometimes it heals on its own without surgery. So there's many options.
Right, and you can't allow wishful thinking. I mean, you have to sit down with the patient and say, look, we like this to heal in 4 weeks, but yours is just not healing in 4 weeks. And I'll use an analogy. It's never the same one, but an analogy like, look, we're baking cupcakes here, and we're just putting the little fork into the cupcake and pulling it out, and there's still batter on it. The cupcakes aren't done. To take them out of the oven now, we're not going to have cupcakes. It's not edible. We got to leave them in the oven a little longer. And by hook and by crook, you get the patients to kind of do what you want by using humor. We do a lot of laughing in my office, and it's laughing over things that aren't funny, but what can you do? I mean, you have no choice. You have to sort of laugh at it. Sometimes you're so helpless. you don't really know what to do.
So do you see a lot of breaks from brittle bones and things like that? Is that common, or is it something where they fall and actually hurt themselves? Can seniors actually, I'll say, when I move my mom sometimes when she's having difficulty getting up, she has severe osteoarthritis, I can actually feel her bones as I'm lifting her and feel them bone on bone, and it scares me. I'm always so afraid, could I break her bone just by moving her a certain way?
Well, there's two issues. One is the arthritic joint. When you move it, you hear crepitance. And the second is breaking the actual bone. Sure, if someone gets a little rough lifting your mom out of the wheelchair to transfer, oh yeah, they can break a bone.
Yeah, that's
and
scary.
if they pivot a little too hard, they can break a hip. So yes, there does come a point when you have osteoporosis that a bone will break with very little force. So it's something we want to avoid. There are ways to avoid it, and you have to start when you're in your teenage years. When you're young, you got to be taking that calcium, drinking your milk. You've got to be running around. I don't know what's going to happen with the average 15, 16-year-old this day and age that's been playing Game Boy sitting down. When I was young, everybody was running around outside. And we weren't inside hardly at all. I only had a black and white TV, and there was Pong or whatever that game was, and there was nothing exciting.
They're going to have really good thumb health is what it's going to be.
And now you don't see anyone on the streets, and you don't see the kids running around. And yes, there's organized sports; they go play soccer and what have you, but it isn't like it was. And those kids that are not jumping 50 times a day, they want kids to jump 50 times a day, or running, or putting some impact on, they will have less bone stock when they get into their 20s, and the ability to add bone starts to decrease significantly. And after the age of 30, you're not going to be adding bone. You're going to be starting on the declining phase. So you got to do it while you're young. And the people that aren't doing any activity now, especially the ones that are smoking cigarettes, which impairs bone formation, drinking diet sodas, I don't know what's going to happen. There's going to be a whole crop of people that are going to be the effective age of 90-year-olds when they're 60. And if you're an osteoporotic cripple, that's bad. You're 60 years old and you just turn around and you break a hip, and you have hip surgery, and then you turn and you break an arm, then you break this, and then it's a really bad situation to be in.
We're going to head to a break right now, but when we come back, I would like to address, if this is the proper way to put it, the physiology of an elderly person's bones.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
We represent the Worcester Tree Initiative Young Adult Foresters.
Since 2009, the city has planted 2,800 street trees.
Trees need to be watered 2 to 3 times per week during the summer for 2 years after they've been planted.
Here is one way we help nurture recent planted trees.
We fill the gator bags with water, and water is slowly released into the soil, and it helps the tree establish itself.
As we continue to plant, it's everyone's responsibility to maintain newly planted trees.
To learn more, visit treeworcester.org.
Charter Business helps businesses achieve everyday victories. Want to be victorious today? Call 877-BIZ-BUNDLE. Switch to Charter Business and start saving over $50 a month. You'll enjoy internet 6 times faster than standard DSL, plus phone with unlimited long distance. Saving your business over $50 a month makes for an easy decision. It's indecision that'll cost you. So call 877-BIZ-BUNDLE today. To the victor go the spoils.
Splash into summer with Worcester Wheels to Water. Sign up now for the fun, safe swimming and recreation program running from July 5th through August 12th.
can't have a better summer day than that. You and your friends would be awesome.
Program includes free bus transportation to pools and beaches, recreation programs including sports clinics, arts and crafts, and summer reading. To register, call Friendly House at 508-755-4362 or visit worcesterma.gov. Promotional message provided by the City of Worcester and Charter TV3.
They aimed to eliminate the use of electronic benefit transfer cards to purchase items including tattoos, guns, and pornography.
And new details tonight in a deadly shooting involving a Massachusetts state trooper.
I'm WTAG's Jordan Levy. Join me on The Jordan Levy Show weekday afternoons on Charter TV3. And thank you for choosing Charter.
Welcome back to the Senior Focus. I'm your host, Attorney Nick Paltzis. I'm here with Dr. Cal Barrette and Don Osterguy. Now, I know Don had a question about smoking, but I have to ask you, are elderly patients more susceptible for injuries in their lower extremities? Are they more susceptible to like break an ankle or something like that?
Well, they are more susceptible. There's several reasons for that. The first is, as you become a little bit less active, your bone will start to demineralize. And that doesn't happen to just elderly people. If you're an astronaut, the prime of your muscular youthhood, and you go up into outer space for 3 months, when you come back, your bones are the equivalent of a 90-year-old.
When you say demineralize, what do you mean?
The bone is
They get
very
brittle?
frugal with its calcium.
Okay.
And the saying, if you don't use it, you'll lose it, is very true when it comes to a bone.
Okay.
So the bone is subject to mechanical stresses. And the more mechanical stress, the more jumping you do as a child, the more running and standing and walking you do as an adult, the more your body is going to keep the bone stronger, healthier, and well mineralized with calcium. The less you do, the body is going to say, hey, I don't need to maintain that big store of calcium and minerals in that bone. I'm going to take it away. So in an astronaut, there's no gravity, there's no weight bearing. The body says, oh, I don't need to maintain all of this bone mass, and it takes it away. So it doesn't really particularly matter if you're 90 and you're not particularly active, or if you're 20 and you're not particularly active, or if you have some particular thing like you're on high-dose steroids that sort of leaches away your bone. Once you become osteoporotic, where you don't have very much bone mass, then you have less strength in your bones. And it's sort of like having this pencil, trying to break it, and breaking a pretzel. Right. So clearly I'm going to be able to break a pretzel better, and the pretzel is going to shatter. So the thinner your bones get, the more likely you are that if you twist your ankle or fall or make a misstep, that you're going to break something. And because you're going to be on more medications, there's a chance that your high blood pressure pill might affect you so that you fall. There's a possibility that they may give you some other kind of medication. There's a possibility that your balance may be off a little bit as you get older, and you'd be more likely to stumble or fall. Your vision gets a little bit less, so maybe you don't see that little uneven ground or that step. Or you put rugs on your floor and you're not lifting your feet up as much, you're scuffing a little bit, and you do that so that you have more balance and position sense, and darn it, you trip over that throw rug. So there's a lot of different things that happen as you age that involve the nerves, the sensory nerves in the foot, maybe not giving information to the brain as fast, your balance affected by medications and by age and by medical problems, the very medications that you may be on that may affect your balance or your blood pressure. So there are a lot of things that sort of accumulate when you get older. Not that any one particular one is gonna make you break your ankle, but it's a cumulative effect, so that you'll have a greater chance of having a lower extremity fracture with a relatively minor injury, slipping off the step.
Now you mentioned calcium. Is it vitamin D that's another big one?
Vitamin D and calcium, and as you're exposed less to the sunlight when you're older, you're not going to convert your vitamin D, and it won't be helping you form strong bones. And as the bone gets softer, it's more likely to break. When you're younger, the bone is very strong, and the bone is stronger than the ankle ligaments, for instance. So if you fall down, you're more likely to have an ankle sprain and less likely to break your ankle. When you're older, the bone is less strong than the ankle ligaments. So when you go down and twist your ankle, and hey, spraining your ankle is one of the most common things that happens. It happens whether you're young or whether you're old. The difference is when you're older and the bone is weaker than the ankle ligaments, you are going to shatter that ankle, not sprain your ankle. So it's unusual to sprain an ankle when you're older.
What do you think about
And-
supplements? What if somebody came in and said to you, you know, I have this bottle of calcium supplements and I want to take these calcium supplements. What is
Well,
your...
I think it's a good idea to take calcium supplements on a daily basis. The wrong thing to do is, what patients tell me is they break something, they come in and say, well, I'm really overdosing on my calcium and vitamin D. I'm like, well, yeah, it's a little too late for that. And not only that, you're going to get a kidney stone or some kind of overdose thing because you're taking too much. The idea is that the bone metabolism in your entire body uses 100 milligrams of calcium a day in everybody. And if you don't take in the net equivalent of 100 milligrams of calcium, and I don't mean 100 milligrams, you have to take in more than that, like 1,000 milligrams, in order to get the net effect of 100 milligrams of usable calcium for your body. If you don't do that on a daily basis, let's say you forget one day, you lost 100 milligrams of calcium, and you're never going to get it back. So the more days that you don't take in that usable 100 milligrams of usable calcium, by whatever means you're going to do it, Rolaids 1000s or Tums or whatever you're going to do to get that 100 milligrams of calcium that your body is going to absorb to replace the 100 milligrams that you are going to poop out, you are going to have a net decrease in your bone. And if you do that enough days, that decrease becomes bigger and bigger and bigger, and you will get osteoporosis. So you need to take these supplements every day, and you need to start young or have a good diet when you're young and take the supplements every day to minimize bone loss.
So if your nutritional habits aren't adequate and you don't take in a sufficient amount of calcium,
Every
it
day.
would be a good idea to take not a megadose of
Right.
calcium, but what the body needs every
Every day.
over a prolonged period of time.
The whole course of your life, that prolonged period of time.
If someone has not taken in an adequate amount of calcium or other nutrients that their body needs, that their bones need, or perhaps they haven't been exercising, is it possible to regain?
You know, they do studies on all the time, and certainly I'm not up on that latest literature,
Yeah.
but by trying to increase your activity on a very slow, gradual basis, there are some medications that are available that may add 1 or 2% of your bone mass over the period of a year to 3 years. I mean, there's risk to that. That bone may be brittle. So there are some ways that medical science can do it, but really the best way is for you to do it starting when you're young. Getting the right amount in every day, then relying on medications in which there can be problems with some of these medications.
What I like to tell seniors is that it's never too late to begin to exercise. Exercise helps you no matter what age you are, and that they should begin exercising, not overdo it, not try to do more than they can do, but it helps to at least do something.
Yeah, and I have a little bit of a saying, the rabbit loses the race every time, and the turtle wins. So when people who are older that haven't been doing activities for a while, they want to start doing activities, be a turtle. Slow, gradual increase. Go to a track, walk around once, or a half a time. Do it in a place where you're not going to get stuck out in the middle of nowhere, and you have to get all the way back, and you get some horrible overuse injury. Avoid hills. Bring your water bottle, go to your local high school padded track. You know exactly how much mileage you're doing. Your car is right there. There's people there. And you can do a little bit of walking. And don't go there and say, I feel great, I'm going to walk 5 miles. No, don't do that. Walk 1 lap, quit. And after a week of doing 1 lap, then try 2, and then 3, and then 4. The turtle will win this race, and the rabbit never wins it. There's going to be some overuse injury, some stress reaction in the bone that's painful, and you'll get sidelined for 2 or 3 months recovering from it. And then if you're a rabbit again, this pattern will keep happening. So my advice is be a turtle when it comes to getting back to activities.
Is it appropriate to talk about smoking now that we talked about exercise?
I was just talking to Dr. Barrette during the break about people who have, so we'll say, I'll give you an example. My mother-in-law had a car accident and had to have rods and screws put in her foot. And as time has progressed, things have changed within her foot. She may need surgery again. They had talked about thinking about that. She never went that route, but I think of someone who's a smoker. And does that affect the prognosis for surgery? Does that sometimes factor in and say, gosh, you can't do the surgery, or it's not even a good idea with the way that that person lives their lifestyle currently?
Yeah, smoking is really one of my pet peeves. It so happens that 90% of my personal complications as a foot and ankle orthopedist are in smokers. Nicotine is evil, evil, evil. It turns off the wound healing, so it's very hard to get the wound healed by constricting the blood vessels. So at a time when you need more nutrition healing a wound, you get less. And it increases the risk that you'll get a blood clot that could break off and go to your lungs and kill you. The worst thing it does for me is it turns off bone healing, and that effect does not go away the moment you stop smoking. So for instance, if you break a bone and you're a smoker and you stop smoking, you'll probably heal the wound and you probably won't get a blood clot. But bone healing is off. So it takes 2 to 3 times longer to heal a bone in a smoker. Nicotine does something to bone that impairs its ability to heal. And that effect takes at least 6 months of not being exposed to nicotine before it reverses. So we've done studies where we've taken a group of people and we're fusing 2 bones together, putting one bone into another and trying to get it to grow together. And smokers and non-smokers, clearly the non-smokers heal much quicker. So what if we have the people stop smoking for 4 months? Well, they have the same rate of not healing as someone that's actively smoking. It looks like it's closer to 6 months for bone healing to turn back on. So here we're doing some of these surgeries. And right off the bat, it's very difficult to get the bone healed.
So another reason to stop smoking. Smoking is terrible.
It's
for
terrible.
any number of ailments, and this is just
It's also a
another
nerve
case.
toxin. So I see people come to see me with bilateral, meaning right and left foot pain, night pain, burning, shooting, stinging, radiating. And that's the nerve effect. Nicotine has killed the nerves. So if you drink alcohol, smoke cigarettes, you have a few other medical problems, you're going to get this terrible nerve pain when you're older, and it is not reversible.
Okay, so the word is stop smoking. We're going to head to a break. We'll be right back with Dr. Barrette and Don Ossiai.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Charter TV3 and UMass Memorial Healthcare have teamed up to bring you the latest news and trends in healthcare. Health Watch, presented by UMass Memorial Healthcare, brings you the healthcare topics that are important to you. From stroke prevention to allergies, skincare to sports injury prevention, and nutrition to pregnancy, Health Watch and UMass Memorial Healthcare informed you on the issues that affect you on a daily basis. Health Watch on Charter TV3. For extended interviews with UMass Memorial Healthcare experts, log on to our website.
Fridays on the job in Worcester.
Is that your lunch?
Yeah, just having a few chips, trying to finish some things up.
You should come out to lunch with us. There's a concert on the Common right now.
Oh, really?
Yeah.
Oh, yeah, I'd be game for that.
Yeah, let's go.
Escape the office. Come out to lunch every Friday this summer, beginning June 29th from 11 a.m. to 2 p.m. on the Worcester Common behind City Hall. Produced by the City of Worcester and the Worcester Cultural Coalition. Promotional message provided by the City of Worcester and Charter TV3.
Charter Business helps businesses achieve everyday victories. Want to be victorious today? Pick up the phone, switch to Charter Business, and start saving over $50 a month. You'll enjoy internet 6 times faster than standard DSL. Plus, business phone with unlimited long distance. If saving over $50 a month doesn't make your decision easy, this will. Call now and get up to a $500 gift card. But hurry, because this offer won't last. To the victor go the spoils.
Tornadoes host the Rockland Boulders Friday, July 27th at 7 on Charter TV3.
I'm Kristen Doucette from Worcester News Tonight. Thank you for choosing Charter.
Welcome back to the Senior Focus. I'm attorney Nick Kaltis. I'm here with Dr. Barrette and Donna Osterguy. And you have some experience with people who suffer from diabetes, is that correct?
Yeah, it's really been one of my lifelong interests. When I was at Yale, that was my thesis. So we've really worked hard on diabetes, and it's actually one of my more favorite things to take care of. I don't do the routine diabetic foot care. I don't see patients in my office for trimming nails or anything like that. Although, you know, if you come in and you have that, I'm happy to trim them. But by the time patients come in to see me, there's something has happened to them. They have developed an ulceration that the podiatrist has been unsuccessful in off-weighting, and the shoe wear thing isn't working. There's something not right. And so the podiatrist will send patients to me, the wound care center. They're having wounds that just won't heal. They want to know, all right, well, what can we do to get this wound healed? Is there a bony prominence underneath that has to be removed? Do you have to change the position of the foot in order to get it to heal? What other shoe wear modalities can we do? Back when I first came to Worcester, I was the Fallon foot and ankle orthopedist, and I started the Fallon Diabetic Foot Care Clinic. And we had vascular surgeons, endocrinologists, the infectious disease doctor, the podiatrist. We had everything all arranged, and we went from having a huge number of baloney amputations when I first came. That seemed to be like all I was doing. Things were so far gone that there was nothing to do. They were just so badly infected that they had to lose their legs, to rarely having to take someone's leg off by having this coordinated team approach. So some of these people are still people that I use today. We have it's a much looser organization, the same podiatrists. We all work very closely together. They're taking care of their diabetic population, and when they start thinking they're getting into trouble, then they send the patients to me to be evaluated to figure out, all right, what can we do to stop something from happening that's going to make this patient lose his or her leg? And that is probably the number one fear of just about every diabetic is, I'm afraid I'm going to lose my leg. And sometimes the fear actually is bad because they're so afraid they're going to lose their leg that they don't come in for treatment. Because for the most part, by the time a diabetic is getting into enough trouble that they need me, they don't feel their feet. They often can't see their feet because they got a stomach, you know. So they can't see them, they can't feel them. They may not necessarily have the best social network to look at the feet, so it's easy to ignore it. And they ignore it a lot because of fear, and sometimes that pushes patients into a very bad spot. So I have another saying, one of my famous sayings. If you come in early, it's easier for me. And if it's easier for me, it's easier for you.
Now, everyone has heard of diabetes. What exactly is diabetes? When someone suffers from diabetes, what's happening in their body?
Well, diabetes occurs because the sugar is too high. The body can't process the sugar. There's different reasons for it, whether you're young or old, but for the most part, the sugar builds up in your bloodstream. And when the sugar builds up in your bloodstream, because the body cannot distribute it appropriately to where it's supposed to go, so it builds up in the bloodstream, it starts to do this thing we call equilibrate. So if you shoot off a little perfume in one corner of the room, it's going to equilibrate so that pretty much you can smell it everywhere throughout the room. Well, the same thing happens with the sugar. The sugar that's in the bloodstream is going to do this equilibrate thing so that there's equal parts in the bloodstream and out of the bloodstream. And so it goes into the nerves, for instance. Once the sugar gets into the nerves, it's immediately metabolized into something called sorbitol that can never get out. So if you think of it this way, it's as if you're a hoarder, and everything that comes into your house, once it gets in, it's not getting out. All the Christmas trees, the bags, the garbage, the newspapers, everything, it gets into your house, it can never get out. Well, most of us have seen that Hoarders TV program. You know, you pack up the bathroom first and the corners, and pretty soon it's really difficult to maneuver your way around the house. That's what happens to the nerves. They get stuffed up with sugar, sorbitol, and they don't function normally. So you get a little bit of numbness in your toes, and then in your foot, and then it comes up your leg, and the sugar goes into the tendons too, and the tendons become very brittle, very easy to tear. The joint capsules and the joints themselves, the cartilage becomes brittle, much easier to have an injury, and much easier to, if you have a sprain, to have a much worse injury. The blood vessels, they get calcified from the diabetes, and they don't conduct blood normally. So people get heavier. Then you put more weight on your feet. So there's this whole thing that happens when you become a diabetic and your sugar metabolism is off. Diabetics are not the only ones that get this thing called neuropathy, which is not feeling. You can get it if you have syphilis. That's what all the papers were on neuropathy were about, was syphilis, which affects the spine. Anyone with a spine problem. Anyone that has anything that affects the nerves. So if you've had chemotherapy, you could get neuropathy and poor feeling in your feet, and you can have all the problems that every single diabetic does. If you are a smoker, kills the nerves. You can get neuropathy, and if you add that with a little bit of drinking, a little hepatitis C, HIV, any medical problem, any inflammatory disorder, it seems like women a couple years after a bypass procedure, there's some vitamin thing, I don't know what it is, they get neuropathy. Irritable bowel syndrome, playing with heavy metal when you're younger, working with benzene. There's so many things that cause neuropathy and will make a person look like a diabetic where they don't feel their feet.
When there's this buildup of sugar, are you saying that once a diabetic has sustained this buildup of sugar, you or they are not able to rid themselves of the sugar?
That's right. It's
So
very
it's
difficult to do
very
that.
important for them to keep
there's-
on top of it before that happens.
That's right. I mean, I've had a few patients that have had pancreas transplants, and they seem maybe to get some of their sensation back, but for the average person, that nerve is just not going to function normally. So especially for the juvenile insulin-dependent diabetics that get it when they're 13 or 14, and they are really not controlled, they're going to have a lot of problems when they're 30 and 40. Whereas the average person who's 40 or 50 when they get their diabetes, they're going to be maybe 70 or so before they start losing legs or toes or getting into the terrible problems of this disintegrating foot problem that diabetics get, which is called Charcot.
We've only got about 30 seconds left in our program, but the one question I really need to ask you, the difference between osteoarthritis and osteoporosis.
Osteoarthritis, arthritis is an inflammation of the bone, and it would be where the joint space is narrowed and you're having joint symptoms. And osteoporosis, osteo is bone, porous is porous, so that's a thinning of the bone. So one is an arthritic problem in the joints, and one is a global problem in the bones, which are becoming thinner.
Dr. Barrette?
Why don't we ask her where she's located, Nick, just for our viewers?
Why don't you ask where you're
Where's
located?
your office located, Dr. Barrette? Just
I'm
in case someone
located
wants
in the
to
Worcester
call.
Medical Center, which is part of St. Vincent Hospital.
And do you have a phone number for your clinic? Do you know that offhand?
508-363-6868.
Wonderful.
Dr. Barrette, thank you for joining us today.
You're welcome.
Donna,
Thank
thank
you.
you for joining us today.
Thank
And
you.
join us next week for more Senior Focus.